Management of suspected ovarian masses in premenopausal women. Green Tab Guideline number 62, November 2011. Background and introduction. Up to 10% of women will have some form of surgery during their lifetime for the presence of an ovarian mass. In premenopausal women, almost all ovarian masses and cysts are benign. The overall incidence of a symptomatic ovarian cyst in a premenopausal female being malignant is approximately 1 to 1,000, increasing to 3 to 1,000 at the age of 50. 10% of suspected ovarian masses are ultimately found to be non-ovarian in origin. Many ovarian masses in the premenopausal woman can be managed conservatively. Functional or simple ovarian cysts, such as thin-walled cysts without internal structures, which are less than 50 millimeters maximum diameter, usually resolve over 2 to 3 menstrual cycles without the need for intervention. Table number 1. Types of adnexal masses. Benign ovarian, functional cyst, endometriomas, serous cystadenoma, mucinous cystadenoma, and mature teratoma. Benign non-ovarian, paratubal cyst, hydrosalpinges, tubo-ovarian abscess, peritoneal pseudocyst, appendiceal abscess, diverticular abscess, and pelvic kidney. Primary malignant ovarian, germ cell tumor, epithelial carcinoma, and sex cord tumor. Secondary malignant ovarian, predominantly breast and gastrointestinal carcinoma. Preoperative assessment of women with ovarian masses. What is the role of history and examination in the assessment of women with suspected ovarian masses? A thorough medical history should be taken from the women with specific attention to risk factors or protective factors for ovarian malignancy and a family history of ovarian or breast cancer. Symptoms suggestive of endometriosis should be specifically considered along with any symptoms suggesting possible ovarian malignancy, persistent abdominal distension, appetite change including increased satiety, pelvic or abdominal pain, increased urinary urgency and/or frequency. A careful physical examination of the woman is essential and should include abdominal and vaginal examination and the presence or absence of local lymphadenopathy. In the acute presentation with pain, the diagnosis of accident to the ovarian cyst should be considered torsion, rupture, and hemorrhage. Although clinical examination has poor sensitivity in the detection of ovarian masses, its importance lies in the evaluation of mass tenderness, mobility, nodularity, and ascites. What blood tests should be performed? A serum CA125 assay does not need to be undertaken in all premenopausal women when an ultrasonographic diagnosis of a simple ovarian cyst has been made. Lactate dehydrogenase, LDH, alpha fetoprotein, and human chorionic gonadotrophin should be measured in all women under age 40 with a complex ovarian mass because of the possibility of germ cell tumors. CA125 is unreliable in differentiating benign from malignant ovarian masses in premenopausal women because of the increased rate of false positives and reduced specificity. This as a result of CA125 being raised in numerous conditions including fibroids, endometriosis, adenomyosis, and pelvic infection. It is important to note that only in stage 3 and 4 endometriosis is it likely to be raised to several hundreds or thousands of units per ml. It is also important to note that CA125 is primarily a marker for epithelial ovarian carcinoma and is only raised in 50% of early stage disease. If a serum CA125 assay is raised and less than 200 units per milliliters, further investigation may be appropriate to exclude or treat the common differential diagnosis. When serum CA125 levels are raised, serial monitoring of CA125 may be helpful as rapidly rising levels are more likely to be associated with malignancy than high levels which remain static. If serum CA125 assays more than 200 units per milliliters, discussion with a gynecological oncologist is recommended. What is the role of ultrasound in the assessment of suspected ovarian masses? A pelvic ultrasound is a single most effective way of evaluating an ovarian mass, with transvaginal ultrasonography being preferable due to its increased sensitivity over transabdominal ultrasound. What is the role of the routine use of computed tomography and magnetic resonance imaging or MRI in the assessment of suspected ovarian masses? At the present time, the routine use of computed tomography and MRI for assessment of ovarian masses does not improve the sensitivity or specificity obtained by transvaginal ultrasonography in the detection of ovarian malignancy. What is the best way to estimate the risk of malignancy? An estimation of the risk of malignancy is essential in the assessment of an ovarian mass. Which risk of malignancy index should be used? A systematic review of diagnostic studies concluded that the risk of malignancy index 1 is the most effective for women with suspected ovarian cancer. Calculation of the risk of malignancy index 1. RMI1 combines three pre-surgical features: serum CA125, menopausal status or M, and ultrasound score or U. The RMI is a product of the ultrasound scan score, the menopausal status, and the serum CA125 level or IU per milliliter as follows. RMI is equal to U multiplied by M multiplied by CA125. The ultrasound result is scored 1 point for each of the following characteristics: multilocular cyst, solid areas, metastasis, ascites, and bilateral lesions. U is equal to 0 for an ultrasound score of 0, U is equals to 1 for an ultrasound score of 1, and U is equal to 3 for an ultrasound score of 2 to 5. The menopausal status is scored as 1 equals to premenopausal and 3 equals to postmenopausal. Postmenopausal can be defined as women who have had no period for more than 1 year or women over the age of 50 who have had a hysterectomy. Serum CA125 is measured in international units per milliliters and can vary between 0 to hundreds or even thousands of units. Is there another way to estimate accurately a risk of malignancy in premenopausal women without using a CA125? There are simple ultrasound rules derived from the International Ovarian Tumor Analysis or IOTA group. The use of specific ultrasound morphological findings without CA125 has been shown to have high sensitivity, specificity, and likelihood ratios. If not clearly classifiable from these rules, further investigation by a specialist in gynecological ultrasound is appropriate. Table number 2. International Ovarian Tumor Analysis Group ultrasound rules to classify masses as benign or B rules or malignant or M rules. B rules or benign masses: unilocular cyst, presence of solid components where the largest solid component is less than 7 millimeters, presence of acoustic shadowing, smooth multilocular tumor with a largest diameter less than 100 millimeters, and no blood flow. M rules or malignant masses: irregular solid tumor, ascites, at least 4 papillary structures, irregular multilocular solid tumor with largest diameter of greater than or equal to 100 millimeters, and a very strong blood flow. Management of ovarian masses presumed to be benign in non-emergency situations. Can asymptomatic women with simple ovarian cyst be managed expectantly? Women with small, less than 50 millimeters in diameter, simple ovarian cysts generally do not require follow-up, as the cysts are very likely to be physiological and almost always resolve within 3 menstrual cycles. Women with simple ovarian cysts of 50 to 70 millimeters in diameter should have yearly ultrasound follow-up, and those with larger simple cysts should be considered for either further imaging, MRI, or surgical intervention. How should persistent, asymptomatic ovarian cysts be managed? Ovarian cysts that persist or increase in size are unlikely to be functional and may warrant surgical management. Ovarian cysts that persist or increase in size after several cycles are unlikely to be functional. Mature cystic teratomas or dermoid cysts have been shown to grow over time, increasing the risk of pain and ovarian accidents. Surgical management is therefore usually appropriate. Does the use of combined oral contraceptives help in the treatment of functional ovarian cyst? The use of the combined oral contraceptive pill does not promote the resolution of functional ovarian cyst. Is the laparoscopic approach better for the elective surgical management of ovarian masses? The laparoscopic approach for elective surgical management of ovarian masses presumed to be benign is associated with lower post-operative morbidity and shorter recovery time and is preferred to laparotomy in suitable patients. Laparoscopic management is cost-effective because of the associated earlier discharge and return to work. In the presence of large masses with solid components, for example, large dermoid cyst, laparotomy may be appropriate. Who should perform laparoscopic surgery for a presumed benign ovarian cyst? Laparoscopic management of presumed benign ovarian cyst should be undertaken by a surgeon with suitable experience and appropriate equipment whenever local facilities permit. Should an ovarian cyst be aspirated? Aspiration of ovarian cyst, either vaginally or laparoscopically, is less effective and is associated with a high rate of recurrence. The recurrence rates after laparoscopic needle aspiration of simple cysts range from 53% to as high as 84%. Is it important to avoid unplanned rupture of the cyst? Spillage of cyst contents should be avoided where possible as preoperative and intraoperative assessment cannot absolutely preclude malignancy. Chemical peritonitis due to spillage of dermoid cyst contents has been reported in different series to occur in less than 0.2% of cases. If inadvertent spillage does occur, meticulous peritoneal lavage of the peritoneal cavity should be performed using large amounts of warm fluid. Use of cold irrigation fluid may not only cause hypothermia, but it will also make retrieval of the contents more challenging by solidifying the fat-rich contents. Any solid contents should be removed using an appropriate bag. In the case of endometrioma, greater than 30 millimeters in diameter, the histology should be obtained to identify endometriosis and to exclude rare cases of malignancy. Consideration should be given to the use of a tissue bag to avoid peritoneal spill of cystic contents, bearing in mind the likely preoperative diagnosis. When should an oophorectomy be performed? The possibility of removing an ovary should be discussed with the woman preoperatively. The pros and cons of electively removing an ovary should be discussed, taking into consideration the woman's preference and the specific clinical scenario. How should an ovarian mass be removed? Where possible, removal of benign ovarian masses should be via the umbilical port. This results in less post-operative pain and a quicker retrieval time than when using lateral ports of the same size.